Thank you very much for the invitation, Yanni, and thank you for the introduction. So I will try, because it's Saturday and it's summer, and I think we all think also about the weather outside. I'll try to show you two cases. The first case is going to be just a normal, let's say, boring tricuspid case, and the second one is going to be really a catastrophe. And we're going to try not to do like tip and tricks. How do we handle the device in order to achieve the result that we want? I will try maybe to point out that it's important to understand the pathology, the etiology, and if we should do something, and if we should do something, which strategy we need to choose. So let's move on. We have the patient that I want to show you, 76 years old, has lower extremity edema, hepatic congestion, dyspnea. He has his OMT already, but it doesn't work. And he does not have like a really bad right heart. On the contrary, TAPSE is okay, and the pulmonary artery pressures are also not that bad. So we have this, of course, tricuspid regurgitation, what else? And we have a good patient regarding 3D imaging, which is also nice to have sometimes. We have the typical position with the aortic valve at 7 o'clock, serving as a landmark, marking the junction between septal and anterior leaflet. And of course, with a straightforward clip strategy, we achieved a good result, which is satisfactory for such a standard patient. The second patient was a little different. He came with other symptoms. He's 70 years old. He presented to the emergency department with acute retrosternal pain radiating to the interscapular region and had dyspnea. He had a shock situation on admission, hypotension and tachycardia, and he has a history of aortic arch operation due to a type A dissection. So therefore, due to the high-risk constellation, we performed a CT that showed this not that nice result, and the left lung was practically white, was not we're not able to see it at all due to the result. I'll show you the angio. We practically have a contrast medium leakage beneath the intima extending through the media, probably only having the adventitial layer outside holding it, and the patient was like had a contained aortic rupture. We proceeded with immediate TEER in order to stabilize the patient, and this is what you see now with the Gore prosthesis. And after that, we had a good result, a good sealing, and the subclavian artery was also nice. But this was not the reason why I wanted to show you this patient. After getting to the ICU and thinking that the job is done, the real problems began, and he had really torrential tricuspid regurgitation. He was really unstable. We had massive dilatation of the right heart chambers. We had a loss of coaptation between all leaflets, a real overload of the right heart. The liver was not working fine. As usual, AST levels higher as ALT and GLDH also. So liver also not working nice due to the right heart problematic, and of course, right ventricular dysfunction. So what do you do with such a patient? Do you have options? This is the big question, and I will answer this question at the end of the presentation, because now I will show you some slides with diagrams, and I don't want you to to be bored. So I'll keep it for the end of the presentation, what we did with this patient. So I would just like to say that it's really important to understand what we do and what the constellation is on the tricuspid valve. The classification is very, very important. If we usually have our 3-leaflet configuration, it's fine. The second, more frequent, is definitely the 4-leaflet configuration, where we have a divided posterior leaflet, but we have also much more not convenient constellations. So understanding if you have a 4-leaflet configuration is crucial. 5-leaflet is practically dramatic, but 4-leaflet is not a good sign. So getting the anatomy the right way is important. There are real data that show that the 4-leaflet configuration practically is associated with increased risk of residual relevant TR after the procedure, and it is really here practically sorry about that. I think it's impressive if you see that you have a 4-leaflet configuration, a coaptation gap of more than 7 millimeters, and not the anterociptal commissure jet that we all like. Automatically, you have a probability of 45% of having residual TR. I mean, if you go on the right side of this slide, it's particularly impressive. You know before you go in the procedure that it's not probably going to work like dropping a coin. And you have some simple methods to see that. So yesterday I asked the question to stent or not to stent. I thought Shakespeare and Hamlet, that was the question. Maybe I was wrong. It was not stent or not to stent. I think he said to TEER or not to TEER. I'm going to get that by the end of the weekend. And or to replace. Don't worry, Ioannis, I will not talk about replacement. Mr. Spargias will do that later. We can practically see regarding the feasibility on the screen when we do the screening what is possible. If we have a small a gap smaller than 7 and at the receptal jet location, if you have 2 or 3 leaflets, no pacemaker, and good echo, like the fantastic pictures Mihalis showed us before, it's a great case for TEER, and it's feasible. It's not about handling the device, it's about understanding the problem and knowing we have a chance to do a good job. You have also the gray zone. We have a gap of 7 to 8.5. Or a posterior septal jet is also feasible, and definitely we can also have a pacemaker in the tricuspid valve. If the leaflet is not being bothered, we can still try it. If that is not the case, then we should consider replacement and go further with other screening via CT. And the baseline severity plays also an important role. We have to consider the baseline TR in order to realize if we have a good chance to achieve our result. Do we have, we can really know today that with increasing baseline severity, the percentage of the patients achieving moderate or less TR decreases. So it is a very nice and clear tool that we can use in order to understand our patient a little better. Definitely, we have seen that the current data show that 1 year survival is significantly higher if we do not achieve our result in the first 30 days. Moderate or less than moderate TR has a positive impact regarding the outcome, and more or less the severity of the residual regurgitation is significantly linked to mortality as a combined endpoint. So these are data that we can see if we follow the patients over 1 year. And so there is an impact on prognosis. And it all depends on underlying etiologies. Do we have ventricular functional regurgitation? You see the echo and the CT beneath. Do we have a functional atrial regurgitation, or do we have a primary regurgitation with leaflet prolapse or flail? And at the end of the day, do we have a pacemaker or a defibrillator or CRT? And if yes, is it feasible to proceed further with the intervention? I don't want anybody to read this diagram. Please don't. I will do the moonwalk and say, if we have a coaptation gap bigger than 8.5, multiple leaflets, tethering and perforation, it's not a TEER patient, and all the others we can consider. And if we have a really, really big coaptation gap, do the CT evaluation and not having an option of like evoke implantation by high-risk patients, we have to think about heterotopic valve implantation if the patient's like almost palliative care and we cannot do anything else. So the guidelines try to adjust with all this data, and we have, it should be considered to do a catheter-based repair or replacement if we have a patient with the constellation that we described before. And the quality of life is key at this moment that drives also the guidelines. And I'm coming at the end of the presentation. We all know that Illuminate data also support the benefit of TEER versus medical treatment. We have a really clear reduction of severity via device compared to medical treatment, which is pretty clear in this diagram. And we have still, of course, quality of life aspects that significantly better after TEER. We have to consider that. It's important for our patients. And nevertheless, we can see over time that initially, although these curves, control group and TEER, do not separate, if we follow up to 2 years, we do see a separation. We do see that the events, the heart failure, rehospitalization, etc., drop. And the question is how many times wants a person to be in the hospital over 1 year. It is also a big question to answer. So we're getting back to the ICU patient. So I hope that everybody's sitting and has his bottle up. We're going to take off. What did we do with this patient, to TEER or not to TEER? We did real magic. We didn't do anything at all because we didn't have any chance to do anything reasonable. So we optimized medical therapy. We placed a right ventricular impeller to support that. He got off the ICU. The coaptation gap was not nice. The right heart was not nice. We don't have any constellation to do anything reasonable. So less is more. And with that answer, I thank you very much for your attention.
Dr. Shuvy, any comment on this this presentation in view of the discussions we had earlier of how everything looks great in the cases done? It's just that how do you find the patients who are not presenting for consideration for TEER is the question.
I think that this case was an possible urgent tricuspid TEER, which is not a really acceptable concept yet. I remember that in the mitral, we also started with stable patients and okay, maybe it'd be suitable also for urgent mitral intervention. I'll present also a case later. But the data on urgent tricuspid is not really known yet. From our experience, we've done 2 or 3 cases that develop RV failure after RV infarction, and the TR was one of the consequences of it, and we did a relatively urgent tricuspid intervention in order them to improve their RV failure, and they really improved it.
Yes, it's a good point.
This is a question that is not really answered yet.
It's a great point. What we sometimes try to do, it didn't work in this case because the coaptation gap was big. We tried to support that with the right ventricular impeller in order to facilitate that. So I can understand, it's a good point that you make, but definitely I think we are getting too late in the game with all the right heart patients, maybe. I think it's something that's developing right now, and it is not possible for the heart to remodel, and that's why we have with the EVOKE screening all these failures, because it's maybe reasonable in the future if the guidelines allow it to go a little more early in their interventional treatment in order to have more chances.
And probably in this space that you presented, due to the collapse of the lung, of the left lung, the pulmonary pressure might be high.
Yes.
So we have a scenario of an
course.
acute right heart.
That's a great point. Yes, definitely.
Well, very good. Thank you very much, Dr. Patsalis. This is Dr. Spargias.